Hello, I'm John Tsai from the Long Beach VA and UCI School of Medicine. In this video, we will be discussing calcium handling in the body, the role of PTH in calcium disturbances, and the workup and management of hypercalcemia. This is relatively fast-paced and clinically oriented, so please feel free to reach out to me if you have any questions about this topic. Let's start off with a case to whet our appetite on hypercalcemia. We have a 56-year-old female with a history of breast cancer in remission 2 years ago, now admitted for hypercalcemia with a serum calcium of 13.5. The patient is asymptomatic, renal ultrasound shows an absence of kidney stones, and now the creatinine is 2.2, up from a baseline of 1.1. So the first question is, what is the next step in management? And let's talk about that first. So what is the main symptoms of hypercalcemia that we can see in patients who have elevated levels of calcium? Well, if you remember from your medical school, we have a mnemonic called bones, stones, abdominal moans, and psychiatric groans. And this refers to bone pain, as we can see in a lot of patients with hypercalcemia. Nephrolithiasis is where the stones come in. Abdominal moans includes pancreatitis, bowel hypermotility, and constipation caused by hypercalcemia. And then psychiatric groans, including some neuropsychiatric manifestations such as anxiety, depression, and mild cognitive impairment. In addition to these four things, we also see muscle weakness, QT shortening, band keratopathy, of which this is a picture of right here in the eye, as well as acute kidney injury from vasoconstriction of the afferent arteriole leading to the glomerulus. Let's discuss some strategies for immediate management for all patients with hypercalcemia, especially when calcium levels are greater than 12. The first and foremost of this is volume expansion. What this does is it reduces tubular reabsorption and corrects dehydration in patients with hypercalcemia. It's usually effective within the first several hours, up to 6 to 12 hours, a lot of times much sooner than that. And we want to give quite large amounts of fluids, and this includes normal saline 200 to 300 mL per hour, and we typically adjust to keep a urine output of 100 to 150 cc's per hour. In addition, we can also use loop diuretics in these patients, which forces the calcium to be excreted through the renal tubules. Now, I want to caution with the use of diuretics in volume depletion. And unfortunately, loop diuretics are falling a little bit out of favor because a lot of times they can be associated with acute kidney injury or worse than acute kidney injury when you already have a volume depleted patient. So make sure you give fluids before you give a loop diuretic if you're going to be using loop diuretics in the management of hypercalcemia. The second is calcitonin, which inhibits bone resorption. This is also effective within the first several hours, but escape tends to happen over several days. So the typical use of this medication is only about 48 to 72 hours. The next medication, Bisphosphonates, also inhibits bone resorption, but this medication takes a little bit longer to act, but it lasts a little bit longer, and it's effective within 2 to 5 days. And that's the action can take up to several weeks to control the hypercalcemia. These medications include pamidronate, zoledronate, but there is a risk of acute kidney injury and renal failure with some of these medications, and I'll discuss that later on in the slides today. The last is dialysis, so we can always dialyze patients for hypercalcemia, especially if the calcium levels are greater than 18, or if the patient's hypercalcemia is complicated by renal failure, or if they become anuric. So let's talk about workup. So we have the same patient with this 56-year-old female, breast cancer with hypercalcemia of 13.5. What is the next step in workup of this patient? How do we work up his hypercalcemia? So let's begin our discussion on workup of hypercalcemia by reviewing calcium metabolism and the organs that are associated with calcium homeostasis. Recall that the GI system is a source of exogenous calcium. We are able to absorb calcium in the presence of vitamin D, and vitamin D itself is either produced in our skin through UV light, or we can also ingest vitamin D from exogenous sources, namely cholecalciferol and ergocalciferol, as you guys well know. Now, the inactive forms of vitamin D must go through processing through both the liver and kidney in order to become active. First, the liver metabolizes inactive vitamin D to 25-hydroxyvitamin D, and the kidney further metabolizes it to active 1,25-dihydroxyvitamin D. This 1,25-dihydroxyvitamin D is the active form of vitamin D that actually has the activity in the bone and the gut, where it increases storage of calcium in the bone and increases dietary calcium uptake from our gut. The other major player in calcium homeostasis in our body is our parathyroid gland through the action of parathyroid hormone, or PTH. The parathyroid gland is responsive to both vitamin D and calcium in our blood. When our parathyroid gland senses either vitamin D or calcium, it responds by decreasing the production of PTH, which will in turn decrease calcium release from the bones and increase calcium secretion through our kidneys in order to bring our calcium levels down to normal. So you can see if there are any areas that are affected by disease, then it could potentially result in abnormal calcium metabolism and subsequently hypercalcemia. With our understanding of the pathophysiology, we can then build a framework in order for us to distinguish the different causes of hypercalcemia. We can first distinguish between PTH and non-PTH mediated causes. In our PTH-mediated causes, we have our diagnosis of primary hyperparathyroidism and malignancy-related PTHrp elevation. There's also something called familial hypocalciuric hypercalcemia, or FHH, which we will discuss momentarily. From the non-PTH mediated causes, these can be primarily broken down into vitamin D related causes and primary calcium related causes. So let's first talk about primary hyperparathyroidism, the most common form of elevated PTH causing hypercalcemia. This usually presents with high PTH, obviously, high serum calcium levels, and high urine calcium levels. And interestingly enough, even in the setting of a normal PTH can be considered high in somebody with hypercalcemia. So because you have hypercalcemia, you expect the PTH to be decreased, you expect it to be suppressed, and so even if you have a normal PTH, this can be considered high. In 3 to 5% of patients, primary hyperparathyroidism does occur in the setting of an inherited syndrome, such as your multi-endocrine neoplasia syndromes. So if you do have a patient with primary hyperparathyroidism, especially if they're young and they have a family history of multiple neoplasms, multiple malignancies, you want to be screening for these MEN syndromes. In addition, you want to consider ordering a DEXA scan in potentially your older patients with primary hyperparathyroidism, as it can predispose to fractures in a lot of our patients. In patients who are diagnosed with primary hyperparathyroidism, we ultimately want to determine if somebody is a surgical candidate or not. If they are a surgical candidate, we want to obtain localizing studies, and this includes ultrasound, technetium-99 or sestamibi scans, a CT scan or MRI. Most of the time we order a technetium-99 sestamibi scan, which is the diagnostic imaging modality of choice in a lot of these patients. Surgery is curative in almost 100% of patients, so you want to look for these surgical candidates. And in patients who are undergoing surgery, you want to replete the vitamin D levels prior to surgery so that you can assist with calcium absorption post-operatively. A lot of these patients, when you suddenly decrease their parathyroid hormone, the bones will start to resorb all the calcium level, your calcium levels will drop in the blood, and you want to make sure that you're able to absorb all the calcium that you're giving PO as well as IV post-operatively after a parathyroidectomy. If they're not a surgical candidate, we can consider different forms of medical therapy. The first form of medical therapy is something called a calcimimetic, for example, cinacalcet. And what this does, it activates the calcium sensing receptor, causing a decrease in your parathyroid hormone levels. So this results in both a decrease in PTH as well as hypocalcemia in these patients. And this is used in patients that are symptomatic or they're hypercalcemic and their bone density is normal. If the patients do have osteoporosis, bisphosphonates can work to decrease hypercalcemia and correct primary hyperparathyroidism as well. So who should be considered a surgical candidate? Patients with a serum calcium greater than 1 milligram per deciliter above the upper limit of normal, bone density T-scores less than 2.5, or if they've had a fragility fracture or previous vertebral compression fracture due to primary hyperparathyroidism. If patients have renal failure from it, eGFR less than 60, or their 24-hour urinary calcium is greater than 400 milligrams per day, or if they've had kidney stones from it, you want to consider surgery in these patients. In addition, if they're young, usually these patients are good surgical candidates, or if they've had some neurocognitive or neuropsychiatric symptoms that can be attributable to their primary hyperparathyroidism. Again, remember that surgery is the only definitive way to cure these patients. So a little bit of an aside for primary, secondary, and tertiary hyperparathyroidism. As we know, primary hyperparathyroidism is associated with an adenoma or hyperplasia or carcinoma, and it's associated with hypercalcemia. Secondary hyperparathyroidism is due to kidney disease from vitamin deficiency and hypocalcemia, and this causes the PTH to be elevated as a compensatory mechanism. In these cases, a lot of times these patients have hypocalcemia, not hypercalcemia. So secondary hyperparathyroidism is associated with renal failure and hypocalcemia, not hypercalcemia. And in tertiary hyperparathyroidism, we have adenomatous transformation that occurs in the setting of chronic kidney disease. And what happens is that over time, whenever you have a transplant, for example, you correct the underlying vitamin D issue, their PTH levels should return down to normal. But because you've had adenomatous transformation, it essentially mimics primary hyperparathyroidism. You've got overproduction of parathyroid hormone, which is also associated with hypercalcemia. Let's talk about familial hypocalciuric hypercalcemia, or FHH. This also presents with hypercalcemia. This is otherwise known as familial benign hypercalcemia because a lot of times these patients relatively benign, low levels of hypercalcemia. This is due to an inactivating form of calcium sensing receptor, which results in inappropriate parathyroid hormone secretion. It looks like primary hyperparathyroidism, but the way to distinguish it between primary hyperparathyroidism is we look at the urine calcium. So the calcium sensing receptor is also located in the kidney, and the inactivation causes an increase in tubular calcium and magnesium reabsorption. Hence, you get hypocalciuria, and this manifests with less than 100 milligrams of calcium less than 24 hours, or a calcium creatinine clearance ratio that is less than 0.01. These cases of FHH are usually benign. There's no treatment necessary, but you want to consider family screening or genetic testing. And if the patients do have elevated calcium levels beyond kind of 1 or 2 milligrams per deciliter, you may want to consider medical therapy for these patients. Obviously, you can't do surgery in them because there's no target like an adenoma or carcinoma causing the hyperparathyroidism. So lithium is also another uncommon cause of hypercalcemia. It happens in about 15% of lithium-treated patients, and you may have some disturbances in calcium homeostasis. So lithium interacts with the calcium-sensing receptor, usually inhibiting it, and so in this case, you inhibit the calcium-sensing receptor, and the parathyroid hormone levels tend to increase. So it presents very similarly to familial hypocalciuric hypercalcemia with a similar mechanism, although ultimately we don't quite understand why lithium causes these changes. And interestingly enough, the lithium causes multi-gland disorder. Okay. So we've talked about PTH mediated hypercalcemia, including your primary hyperparathyroidism and FHH. And the way to distinguish the two is through the urine calcium levels. If the urine calcium levels are normal to high, then you've got primary hyperparathyroidism. If they're low, you want to be thinking of familial hypocalciuric hypercalcemia and potentially lithium if you have a patient that has a psychiatric disorder on lithium. So let's talk about PTHrp. And if you have elevations in PTHrp, that usually means you have to do a malignancy workup. As you can see here, PTH and PTHrp in panel A, they look very, very similar, which means that they can activate your parathyroid receptor here in panel B very similarly. So they are homologous. And interestingly enough, PTHrp is expressed in non-neoplastic tissues as well. But when you have some sort of tumor, you have an elevation in that expression. And the PTHrp elevation occurs in about 80% of patients with solid tumors. So you want to be thinking of solid tumors whenever you have somebody with an elevated PTHrp, and you want to work out for solid tumors in this case. Interestingly, about 5 to 10% of these patients do have coexisting PTHrp and PTH elevation, suggesting that you potentially have a coexisting primary hyperparathyroidism as well as a malignancy on top of that. So essentially, when we go down the path through to PTHrp-related hypercalcemia, you want to do a workup, especially solid tumors in this case. So let's talk about vitamin D-related hypercalcemia now. So vitamin D-related hypercalcemia typically comes in two different flavors, either high exogenous intake or high endogenous production through whatever mechanism. So you have overdoses of the different forms of vitamin D. So you've got cholecalciferol and ergocalciferol, which is our 25-hydroxy vitamin D, our inactive vitamin D. You also have 125 dihydroxy vitamin D overdose or calcitriol overdose. We have a form of 25 hydroxy vitamin D, which is calcitriol, which is kind of in the middle between these two, and you can overdose on that medication as well. And all of these are associated with low PTH levels. In addition, granulomatous disorders cause an increase in 125 dihydroxy vitamin D through the lymphocytes and macrophages releasing this active form of vitamin D, which then increases the gut calcium absorption and can potentially predispose you to hypercalcemia. So what are the granulomatous disorders that are associated with high vitamin D levels and hypercalcemia? Primarily this is sarcoidosis, but you can also have TB, borreliosis, histoplasmosis, coccidiomycosis, lymphoma, as well as silicone injections and implants. So whenever you have elevations in your active form of vitamin D, in the absence of a known ingestion of vitamin D, you potentially want to be working them up for granulomatous disorders, especially sarcoid or any of these infectious causes listed here. So lymphoma is interesting because the hypercalcemia can actually form either through a granulomatous formation or a PTHrp production. The PTHrp production primarily is a non-Hodgkin's lymphoma, whereas the 125 dihydroxy vitamin D formation and the granulomatous formation is really seen in Hodgkin lymphoma or these other lymphomas here. There are other forms of vitamin D related hypercalcemia, including this idiopathic calcitriol induced hypercalcemia. So this is when we have elevated 125 dihydroxy vitamin D levels, but normal 25 hydroxy vitamin D levels. You have no evidence of granulomatous disease and you have absence of an overdose of calcitriol. These generally respond to low-dose glucocorticoids. Similarly to all vitamin D-related hypercalcemia, they respond pretty well to glucocorticoids, obviously in the absence of a patient who has overdosed on vitamin D supplements. The other thing that we have is something called idiopathic infantile hypercalcemia, and this is due to an inactivating mutation of the 24-hydroxylase enzyme. And this results in higher 125 dihydroxy vitamin D levels in this case here. So we've talked about the vitamin D related hypercalcemia, so now let's talk about calcium related hypercalcemia now. So in calcium related hypercalcemia, we've got a couple of different ways in which hypercalcemia can form. So the first is milk alkali syndrome, and this is associated with alkalosis, which stimulates calcium absorption through the distal tubule. And the alkalosis is usually in combination with a very high calcium ingestion. And I'll talk about a little bit about that on the next slide. Renal failure, especially coupled with an increase in calcium intake, you're not able to release or get rid of the excess calcium when you have renal failure. And this is particularly true in patients who are on dialysis already and we've accidentally put them on a high dialysate bath during dialysis. In addition, some medications, especially thiazide diuretics, can predispose you to getting hypercalcemia through their mechanism. And then we have bone resorption issues, of which there are different flavors, and I'll get to that in a second too. So what is milk alkali syndrome? In the 1920s, patients were actually given milk and alkali as a treatment for gastric ulcers. This was also known as a SIPI regimen, formed for this gentleman, Bertram Welton SIPI, that was developed in the 1920s. And basically, they gave patients milk and bicarbonate to treat their gastric ulcers. It was actually a really good treatment for ulcers, but unfortunately, the patients did develop hypercalcemia, and this was termed Cope syndrome, which was discovered in 1936. We have decreased the incidence of milk alkali syndrome primarily with the development of newer medications, especially our H2 blockers and PPIs that are now, the treatments of choice for gastric ulcers and GI issues. Now, we have seen an increase in calcium supplements, especially for the treatment of osteoporosis, and a lot of times patients are kind of into their fads and whatever they're taking. And so we've seen potentially a mild increase in the number of patients that are being diagnosed with milk alkali syndrome. And interestingly enough, it always occurs in board review or board exams. So you want to be looking out for this in board exams whenever you're taking an examination. You primarily want to look for hypercalcemia, the metabolic alkalosis from the high alkali ingestion, as well as renal insufficiency in these cases. So what are the direct bone resorption problems that cause hypercalcemia? The first is vitamin A toxicity, which results in a direct effect on bone to stimulate the osteoclastic resorption. as well as inhibit osteoblastic formation. And this usually happens in 3 different ways. Either you've been exposed to very high vitamin A levels, either through vitamin A ingestion or through ATRA patients for APML for leukemia, or if you have patients that are taking very high levels of vitamin A in the setting of absence of being able to get rid of that excess vitamin A, such as dialysis patients. Relatively uncommon, but you do see this sometimes. The second is immobility, and this was first described in 1941. It was thought due to an increase in bone resorption, and this is especially worse in the setting of renal failure. And then we have Paget's disease, which causes an increase in bone resorption in localized areas, as well as multiple myeloma, which causes direct bone resorption in certain areas, as is seen in your skeletal survey. So now we've talked about the different forms of calcium-related hypercalcemia. So we can review here. We have your increased calcium intake, which includes your milk alkali syndrome, high calcium dialysate, and high calcium ingestion in rare cases. We have decreased calcium excretion from thiazide diuretics to renal failure, for example, and we have direct bone resorption problems such as vitamin A toxicity, immobility, Paget's disease, and multiple myeloma. So let's go back and review our initial workup of hypercalcemia and what we typically order in terms of lab tests. So the first is to order a parathyroid hormone. I think we generally order a parathyroid hormone in addition to our 25-hydroxyvitamin D, as well as our 1,25-dihydroxyvitamin D and PTHrp levels. So all these 4 things are commonly ordered together, but potentially you can just order a PTHrp if you think the patient may have primary hyperparathyroidism, but that's the first thing you want to exclude. You want to check their medications, make sure they're not on medications that potentially can be causing hypercalcemia. And you want to assess for malignancy in cases that are appropriate, get a chest x-ray for sarcoidosis and any fungal infections, bone surveys for multiple myeloma as appropriate. So let's also go back to therapies for hypercalcemia. So we talked about fluids with volume expansion, with or without Lasix. Calcitonin happens or works very quickly, but escape happens within about 2 to 3 days, so you can't necessarily use these medications for longer than that. Then we have our bisphosphonates, and lastly, of course, we can dialyze patients, especially in the setting of renal failure. I also wanted to talk about steroids and Denosumab, which are 2 of our newer medications or medications that can be used for hypercalcemia. So bisphosphonates, you want to use caution in renal failure. So the clinical trials of zoledronic acid did include patients with a creatinine up to 4.5. So if you are using bisphosphonates, you may want to check your creatinine, make sure the creatinine is not above 4.5. There are some case reports of successful use of pamidronate in patients with multiple myeloma and renal failure, including hemodialysis patients. But technically, these are special cases, and one should be cautious of using bisphosphonates in the setting of renal failure. IV bisphosphonates are more commonly a cause of nephrotoxicity compared to oral bisphosphonates, so you want to be considering that as well. And the way it causes nephrotoxicity potentially is acute tubular necrosis in zoledronic acid, or something called collapsing FSGS in the setting of pamidronate. There are case reports of this. There is the other complication to bisphosphonates, primarily osteonecrosis of the jaw, which happens primarily in high-dose IV bisphosphonates among cancer patients. So be careful in cancer patients and bisphosphonates causing osteonecrosis of the jaw. As I said before, steroids work fairly well in hypercalcemia, especially in patients with vitamin D-related hypercalcemia. We typically give them prednisone 20 to 40 milligrams per day and taper them off once their calcium levels start to come down. And it's effective within 2 to 5 days. So it's not going to be effective immediately, but you want to get the medications on, especially if you have a vitamin D-related hypercalcemia in the absence of an overdose of vitamin D. So Denosumab, or Prolia, is one of our newer medications. It's a RANG ligand inhibitor that inhibits bone resorption. So this decreases the calcium by decreasing the bone resorption. And we use it in patients who are refractory to zoledronic acid or where bisphosphonates are contraindicated, especially in settings where you have renal impairment or dialysis patients where Denosumab can be used in those settings. There are no clinical trials comparing zoledronic acid to Denosumab in hypercalcemia, but we know it works, and it actually causes hypocalcemia in a lot of patients. This medication is unfortunately restricted to endocrinology, so a lot of times when we get patients who would qualify or can benefit from Denosumab, we get our endocrinology colleagues involved with these cases as well. So the take-home points in this presentation, when we think about hypercalcemia, we want to be thinking about the different etiologies of hypercalcemia, PTH, vitamin D, bone-related hypercalcemia causes. You want to develop a differential diagnosis based upon the lab test that you order, primarily PTH, vitamin D levels, and you want to take a good history as well. Make sure they don't have any exposures, any foreign travel or any interesting travel points, or any exposures to beryllium or things like that that can cause granulomatous disorders. And then you want to target therapies. Fluids is kind of our first line therapies with or without loop diuretics. Calcitonin, bisphosphonates or denosumab, which act a little bit later, steroids in vitamin D patients, and dialysis if you have patients with severe hypercalcemia in the setting of renal failure as well. So let's review again our framework for hypercalcemia. You want to check PTH levels, and if the PTH is high, you want to be thinking of primary hyperparathyroidism or familial hypocalciuric hypercalcemia, as well as PTHrp in these cases. And then when you look at non-PTH mediated, you want to be thinking about the vitamin D related causes and the calcium related causes. The PTH mediated causes, again, primary hyperparathyroidism and familial hypocalciuric hypercalcemia, as well as PTHrp. And if you have a PTHrp that's elevated, you want to be thinking of your malignancy workup, especially solid tumors. In the vitamin D related category, we have 25-hydroxy vitamin D mediated, and these are usually your ergocalciferol and cholecalciferol overdoses. And then you have your active 125 dihydroxy vitamin D level mediated hypercalcemia, which is in the setting of your granulomatous disorders, calcitriol overdose, idiopathic calcitriol induced hypercalcemia, or idiopathic infantile hypercalcemia here, which are much more rare causes of hypercalcemia. And then in our calcium-mediated hypercalcemia, we have increased calcium intake, which occurs in the setting of milk alkali syndrome, high dialysate calcium, high calcium ingestion, or we have a decreased calcium excretion, such as in our thiazide diuretics and renal failure, and then direct bone resorption etiologies, such as our vitamin A toxicity, immobility, Paget's disease, and multiple myeloma. So that's all I have for you guys today. Thank you very much for joining me. And again, if you have any questions, please feel free to reach out to me. Thank you and have a great rest of your day.